Assalamu alaikum. Let's discuss about some important topics regarding musculoskeletal system. Start with the differential diagnosis of neck pain. Okay. Differential diagnosis of the neck pain. First, strain. It is antecedent history of the neck injury and pain and stiffness with neck movement. In the neck, near is flexion, extension, lateral rotation, and lateral flexion. These are the movements. If you find pain and stiffness doing these sort of movements, it may be neck strain. So neck movements are usually flexion, extension, lateral flexion, and lateral rotation. Okay, now focal osteoarthritis. It happens in the older individual, pain and stiffness worse with movement. Pain and stiffness worse with movement, and it is relieved with rest. So worse with movement, relieved with rest. Radiculopathy. Radiculopathy means pain radiates to the arm and shoulder. So if neck pain radiates to the arm and shoulder, it is radiculopathy. There is dermatomal sensory motor reflex finding. There is positive spiralings and very high yield sign for diagnosing the radiculopathy. Like if you want to diagnose the cervical radiculopathy, this is one of the classic signs, like positive spiraling test. And spondylitic myelopathy. Spondylitic myelopathy, it may be lower limb weakness, gait, bowel, bladder dysfunction. There may be Lhermitte sign is positive. Lhermitte sign is also positive in multiple sclerosis. It is like if you extend the knee, there is electric shock like sensation. So spondylitic myelopathy, there is a positive Lhermitte sign, and there is lower limb weakness. Spondyloarthropathy, a young man, HLB27 positive, relieved with exercise and prolonged morning stiffness. So young man, HLB27, relieved with exercise and positive, prolonged morning stiffness. And another is in spinal metastasis, there is constant pain, worse at night, constant pain, worse at night, not responsive to position changes, very, very, very high yield. Spondyloarthropathies are relieved with exercise. There is prolonged morning stiffness, but spinal metastasis, like as it is cancer, it is metastasis, so there is constant pain, worse at night. And osteomyelitis is infection. There is focal tenderness, fever, and night sweat, IV drug abuse or immunocomplex, and recent infection. What is a likely diagnosis in a child with Down syndrome? That presence with behavioral change, urinary incontinence, Down syndrome, presence with behavioral change, urinary incontinence, and upper motor neuron symptoms. If behavioral change, urinary incontinence, and upper motor neuron symptoms, it is atlantoaxial, it is atlantoaxial instability, due to compression of the spinal cord. It is due to atlantation instability due to compression of the spinal cord, and treatment consists of surgical fusion of C1 and C2 cervical vertebra. So in atlantoaxial instability, just fuse the C1 and C2. Excessive mobility of the vertebra C1 and C2, which can cause subluxation of the cervical spine and spinal cord compression. Symptoms include pain, ataxia, incontinence, quadriparesis, and quadriplegia. Spondylosis. Cervical spondylosis is cervical spine degeneration. It is mm, mm, marked by cervical spine degeneration. It is generally associated with two clinical symptoms. There is cervical radiculopathy, there is compressive cervical myelopathy. So, spinal spondylosis, there is cervical radiculopathy and cervical compressive myelopathy. In cervical radiculopathy, there is degeneration and osteophyte formation in the zygofascial facet. In the zygofascial and ancovertebral joint lead to intervertebral foramen narrowing and compressive nerve root symptoms. So cervical radiculopathy, there is degeneration and osteophyte formation in the zygofascial and ancovertebral joint. Zygofascial and ancovertebral joint lead to intervertebral foramen and narrowing and compressive nerve root symptom. Most patients have severe neck, shoulder, arm pain plus weakness in myotome and sensory loss in a dermatome. Weakness in myotome and sensory loss in dermatome. In compressive cervical myelopathy, there is degeneration and thickening of the lateral vertebral bodies and posterior longitudinal ligament. So, in compressive cervical myelopathy, there is degeneration and thickening of the lateral vertebral. There is degeneration and thickening of the lateral vertebral bodies and posterior longitudinal ligament lead to spinal canal, narrowing and subsequent spinal cord compression. In radiculopathy, there is a nerve root compression. In myelopathy, it is spinal cord compression happening due to thickening of the lateral vertebral bodies and the posterior longitudinal ligament. These usually present with neck pain, lower motor neuron signs, neck pain, lower motor neuron signs in the upper extremity, and upper motor neuron signs in the lower extremity. There may be bowel, bladder dysfunction. Lower motor neuron signs in the upper extremity, upper motor, lower extremity, bowel, bladder dysfunction. What is the likely diagnosis in an elderly patient with a right-sided neck pain, sensory deficit over the posterior forearm? Physical examination, limited neck rotation, and lateral bending. It is a cervical spondylosis. Limited neck rotation and lateral bending is due to osteoarthritis with secondary muscle spasm. Sensory deficit is due to osteophyte-induced radiculopathy. Now a very high health box. It is called cervical radiculopathy. In cervical radiculopathy, the nerve root are C5, 6, 7, 8, and T1. C5 in C5 nerve root compression. The reflex affected C5 biceps, C6 biceps and brachioradialis, C7 is triceps, C8 is finger flexion, and T1 is also finger flexor. And these two, C8 and T1, not typically evaluated clinically. Now, if there is C5 nerve root compression and C5 or disc space is C4 to C5, There is a sensory loss over lateral upper arm, sensory loss or lateral upper arm in C5, in C6, thumb and index finger in C7, middle finger and dorsal forearm, middle finger and dorsal forearm. In C8 there is ring and little finger, and in T1 there is medial forearm. So again, if you want to remember the sensory loss, C5 is lateral upper arm, lateral upper arm. C6 is thumb and index finger. C7 is middle finger and dorsal forearm. C7 is middle finger and dorsal forearm. C8 is ring, a ring. C8 is ring and little finger, and T1 is medial forearm. For C5, what are the weak? If C5 nerve root compression or C5, C4 to C5 disc space involvement, there is weakness in the shoulder abduction, deltoid, shoulder abduction, and elbow flexion, biceps. So shoulder abduction, abduction, and there is elbow flexion, and C6 again elbow flexion, which is bicep. There is forearm pronation, supination, forearm supination, pronation, supination, pronation. There is wrist extension. So for C6, there is elbow flexion, forearm pronation, supination, pronation, and there is wrist extension. In C7, there again elbow extension, wrist flexion, elbow, ex, elbow extension, elbow extension, wrist flexion, and finger extension. And C8 to T1 finger flexion and extension, thumb flexion and abduction. In T1 for finger abduction and adduction. These are the cervical radiculopathy. In radiculopathy occur due to disc herniation, abrupt onset spondylosis, spinal spondylosis, subacute progressive. Clinical imaging not required with mild symptom, NSAID, and evidence of provocative shoulder abduction. Shoulder abduction reduces tension in the on the impinged nerve root and improvement of radicular symptom when the hands when the hand is placed on the top of the head, like abduction reliefs, and shoulder abduction reduces tension on the impinged nerve, improvement of radicular symptoms when the hand is placed on the top of the head. Shoulder abduction relief test. It can both diagnostic and therapeutic for short-term relief, and MRI is recommended only for patients with severe progressive bilateral neurological deficit, or in these high concern malignancy, epidermolysis cervical myelopathy or cervical spondylotic myelopathy. Age more than 55, degeneration of the cervical spinal disc, canal stenosis, there may be cord compression, there may be gait disturbance, there is upper motor neuron sign in the legs, lower motor neuron sign in the arms. So upper motor neuron sign, Babinski hyperreflection, lower motor neuron sign, there may be gait dysfunction, and there is decreased proprioception and pain sensation, proprioception, vibration, pain sensation, MRI of the cervical spine, and CT myelogram. Non-surgical is immobilization and surgical is decompression. An electric shock-like sensation with the forward flexion of the neck, Larmit sign, MRI of the cervical spine is the first choice, but myelography is often required. Differential diagnosis ALS, MS, but it does not cause lower motor neuron sign. Okay, the final is vertebral compression fracture. It may be due to trauma, bone metastasis, osteoporosis, metabolic hyperparathyroidism, Paget's disease. There is acute back pain, decreased spine mobility, referred to abdomen and flank, referred pain, abdomen, flank, pain increasing with standing or walking or lying on back, spinal tenderness at the affected level. Chronic is painless, progressive kyphosis, loss of weight, increased risk for future fracture. In vertebral compression fracture, there is increased risk for future fracture, hyperkyphosis, protuberant abdomen, early satiety, and weight loss, decreased respiratory capacity. This is called hyperkyphosis. So that is all about vertebral compression, cervical pathology, and differential diagnosis of the neck pain. Hope you enjoyed.